Now we will see the management of some common extraocular diseases, starting with the Epiphora, gland prolapse, scrolled Nictitans, Entropion, conjunctivitis, ulcers on the cornea, caseous. Then opacity is not a diagnosis, but it is a part of the clinical sign. Then uveitis. Again, hyphema is not a diagnosis, it is a part of the clinical sign. Trauma and proptosis of the eyeball, eyelid lacerations, then little on cataract and glaucoma. What are the surgeries at present which we are commonly doing? Epiphora is a very common problem which we have seen also, where you have to use a that is a Jones test. So the fluorescent can be instilled onto the eye, so to check the patency of the nasolacrimal duct. So in the last picture, actually you can see here, it is a brown pigment. So normally this is a chronic epiphora. So this brown pigmentation is mainly due to the presence of the lactoferrin that is present in the tear film. So that is actually causing this brown pigment, and various reports are also there saying that you can also treat it empirically. You cannot stop epiphora, but at the same time the stain can be removed with the help of some stain removal are available, but with the doxycycline, when you administer, you will be able to get a clear tear film. So normally they follow this during the dog show. In case of French bulldog also, you have to check for the oropharynx also, for the infiltration or for the escape of the dye into the oropharynx, because of the tortuous nature of the nasolacrimal duct in brachycephalic dogs. In appearance of the or inability to show the stain in the nasal ostium is not a sign that it is a blocked NLD. Punctal cannulation. So in such cases, sometimes you may have to do a cannulate the puncta and then proceed. So you can use either make the 26 gauge needle blunt and then use, if this is in fact the best. You can also use punctal cannulas that are available presently, but which will be having the cannulation, the angulation will be different, which will not suit the animal's angulation. So I prefer to use a 26, or you can also use a viscoelastic needle, which comes along with your viscoelastic material, which when we use for cataract surgery. So irrigation of this nasolacrimal duct is, though you say it is a minor procedure, many textbooks have also said that it can be done under sedation with the topical anesthesia. Sedation, maybe probably in case of young dogs, if they have a good cardiac vascular status, you can proceed with the psilocin sedation and then topical anesthesia, but not with other sedations. And if at all, if there is going to be a block, and you know the nasal ostium and all is very sensitive, so the animal will try to shake its head, and sometimes you can cause more injuries. So always try to go ahead with a short GA. So the basic principles are like any venipuncture. So you know where the duct is. So follow the same parallel course of the duct when you direct the needle, and seat the needle deep into the duct. That is very important. You are not seeing the stem of the needle at all. So you have to further go down and then keep the hand there, so that you will be able to get a good control when you actually inject the fluid. Now we will see in this video like how the nasolacrimal nasolacrimal irrigation is done. So this is necessary in case of most of the epiphora. So now I am trying to inject the fluorescent dye again through the nasolacrimal duct. So, and now we are trying to pressurize, but we are feeling some resistance. So when you feel resistance, what you can do is you can adjust the needle and bring forth and backwards, and then you can again try pushing it. So you are seeing here that the fluid escapes as a backflow and also through the upper punctum. It is not escaping through the nasal ostium. So through the upper punctum, most of the fluids are coming out because of the block in the distal area. Now what you can do is you can close the upper punctum with your finger and then apply pressure. Just a thumb pressure is sufficient on the upper area. So you have to put pressure on that area with your finger and then try to, yes, now we have applied pressure, and now what you are trying to do, you are trying to close the upper punctum with pressure so that the fluid will not escape through that area. So what will happen when you apply pressure on the piston, the fluid will be forced to go through the nasolacrimal duct only. If there is a block, you will be able to relieve the block. Now we can see the piston moving little down and the fluid is coming down through the nasal ostium. So this technique you should follow whenever there is a block in the nasolacrimal duct. This is very important. And now you can see the flow. And followed by this, we can again clear the nasolacrimal duct with additional amount of distilled water. Then you can also use, I also like to use antibiotics. Also, we can flush through this same method. Then this is a nasolacrimal duct flushing, which you can see in case of a cat. So usually you will find most of the cats, the punctum will be blocked due to infections on the conjunctiva, severe conjunctivitis or viral conjunctivitis due to herpes, you see. So you can always sedate the cat and use the cannula, IV cannula, and then cannulate and then proceed for the nasolacrimal irrigation. Now, nasolacrimal irrigation or the punctal cannulation is not just done for Epiphora alone. There are other areas where you have to do. For example, if it is a Nictitans gland prolapse or conjunctivitis, conjunctivitis will be normally followed by the block of the nasolacrimal duct. And if there is an irregularly shaped lower eyelid or severe cases or conjunctivitis or lacerations on the lower conjunctiva, definitely you don't have to take any bite around the punctum. So definitely cannulate the punctum and then do if there is a tear or a laceration near the medial canthus, cannulate the punctum, and that should be there throughout the procedure till you finish the suturing on the eyelid. And then followed by that, you can also check whether the punctum is patent after your suturing on the lower eyelid. Some other procedures which you normally get in the pathology is the Hordeolum. So here you can see a small reddish brown, reddish structure on the medial canthus near the upper eyelid. So they are all style-like infections of the sebaceous glands. So sometimes they appear little away from the eyelid like this, or it can also occur along the margin of the third eyelid. Some in case of meibomian gland style, actually it will all be shown outside. So when you lift the, you will see a small bulging. When you try to retract the eyelid up, you will see the meibomian gland adenitis. So in such cases, you can use chloramphenicol with the cortisone. That is very important. You can use, or you can also use other plain antibiotics like gatifloxacin or tobramycin. Then blepharitis is also one very common condition, commonly accompanied to any other dermatological lesions. So you have blepharitis angularis as well as ciliaris. Angularis is the involvement of the angles, only the medial and the lateral canthus, where the animal will have severe itching, and in ciliaris, they will have a marginal blepharitis. So mainly because of the hair follicles. So this will appear uniformly in both the upper and the lower eyelids, whereas especially the opening of the sebaceous glands. So you will find infection. So they are all non-ulcerative blepharitis, very simple blepharitis, also called seborrheic blepharitis. So these should be attended along with first take care of the skin infection, then the local infection can be attended. So definitely you need some good antibiotics to treat such cases. Preferably we use ointments rather than eye drops for treating blepharitis, so that you will get a good lubrication also, and it stays there for a prolonged period on the eyelid. So you can apply that and it stays there. But one thing what we have seen from the animal's point of view is, when you put drops, there will be some good cooperation from the patient. Whenever you put some ointments, they will have a tendency to rub the ointment. So E-collar is a must. When anything you treat on the eye, E-collar is a must. Then you can put the eye ointment. Otherwise, without an E-collar, when you put an eye ointment, it will cause more harm. So then the Nictitans gland, cherry eye, which is a very common thing, which you have in the first, you can see a very small Nictitans gland that is proptosed out. Gland prolapse can occur even due to dehydration. So that always you should keep in mind, and hydrate the animal thoroughly, and then followed by that you can also, I have seen pushing the gland back into the area with the help of some local anesthetic, and sometimes, very rarely, it will stay. But if it is an anatomical defect, any anatomical defect has to be attended by a surgeon. Now here in the lower picture you can see the infected Nictitans gland. It also looks like little tumorous. So in any tumorous Nictitans gland you are not supposed to reposition. By the gross appearance of the gland, you will be able to say whether you can replace it or not. In the third picture, we have a smooth mucous membrane covering the Nictitans gland. That is very important for the repositioning of the Nictitans. So this Nictitans gland repositioning is very important. One thing, because it actually secretes about 30 to 40% of the aqueous portion of the tear film. So the gland can be exposed. This is actually an amateur picture which we have done for a long time back. Just to want to show you the different types of drapes which we were using initially. These are not adhesive drapes. So two parallel incisions can be applied on either side, and that small piece of the tissue can be removed from the conjunctiva and from the gland surface, and then you can make a pocket on either side and then start closing the, sometimes what will happen, you will not be able to depress it. So start closing, at the same time try to depress the gland, then it will stay in position. So Nictitans gland repositioning is a very important procedure. But this is one method only I have shown, that is a pocketing method, which can be used for simple glands like this, small sized glands, Nictitans gland. But if it is going to be very long and if it is going to happen in a large giant breed dogs, you definitely go for a orbital rim anchorage technique. Entropion is a very common condition where, depending upon the turning of the eyelids, lower entropion is more common when compared to upper eyelid entropion, and depending upon the number of turns the eyelid takes, you can also grade the entropion as 1, 2, 3, etc. See that you can very well see in this video, the lower eyelid is curled and the hairs directly irritating the corneal surface. So that is why you have blepharospasm, and if it is left unattended, it will also go for corneal ulcer, then also for focal superficial keratitis. Then in advanced cases, you will also find some scarring and pigmentation and neovascularization. So it is always better to attend to this and not at the puppyhood. These are all congenital problems, and when you attend also conditions like entropion in a bilateral patient like this, it is better to address to both the eyes in the same sitting. So advanced cases of entropion can cause opacity and pigmentations on the cornea, and it will also go for sometimes caseous thick mucoid discharge you will find. And this breed is very Sharpie is a very common breed where they don't have, because of the excess fold of skin. It is not just an entropion of one upper or lower eyelid, it is the whole skin is very because of the slackness or the nature of the eyelid. What happens is it droops over the eyeball. So whenever the animal try to look into or try to focus a sub object, what happens, it won't be able to do. In doing so, it will try to do more, and that will cause irritation. In this video actually you can see here the animal is now positioned and then it is kept on the anesthetic apparatus. It is under general anesthesia. So this patient preparation itself needs a general anesthesia. So now coming back to our first point, that is microsurgery, time is trauma, is very important. So the anesthesia starts from the preparation of the site. It is not like other surgery where preparation of the site can be done under sedation, and under general anesthesia you can actually do the surgery, but here it is not so. So this is an entropion patient in a, you can see the upper fold of skin that is actually occupying the area. So we have done a Wyman entropion surgery where both the upper eyelid and lower eyelid at the lateral canthus, a circular piece of skin is removed and then it is sutured. So bilaterally it is attended to. So this was the corneal irritation that was kept present here in this animal, and now you can see the fundus. Here you can see the tapetum also. So animal is happy, the patient is happy, the pet parents are also happy. In such cases, it is always better to inform the because they will be hesitant when they hear about this surgery. You can also show the surgeries which you have done. You have to explain to them. Then they will understand the importance and they will proceed. Otherwise, there is no point in making the animal eye blind like this and then proceeding for such surgeries. So if there is a delay in deciding whether to go ahead with the Entropion actual surgery or not, you can always put a aborted Madras sutures. They are called the tacking sutures. We can put it on the upper eyelid or wherever. If it is on the upper eyelid is causing the problem, you can put it on the upper eyelid, and then you can prevent the irritation of the upper eyelid onto the corneal ulcer, and you can also stop a painful blepharospasm. So this is very common in spastic entropions, or if there is an acute onset of entropion and you are not actually sure whether it's upper eyelid or the lower eyelid or how much to remove, you can always do a tacking so that there will not be any painful blepharospasm, and constant irritation of the on the cornea also can be prevented, and then you can wait for some time and look for the actual cause. So in case of lower eyelid also, I always prefer to put the sutures along like this and then bring everything together and then put a suture distally like this, so that the sutures also will not be directed towards the cornea, and that will not cause any infection, any irritation on the cornea. You might have heard about trichiasis. It's a condition where the improperly positioned eyelids, the cilia will be directed towards the cornea. So here I will say it is suture trichiasis. So do not result in suture trichiasis. So you have to definitely hold all the sutures, cut long enough, and then actually you can tie it and then fix it in the with the stay suture. Yes, trichiasis is again a very common condition, and that causes nasal pigmentation in case of brachycephalic breeds, especially pugs, where you will find a pigmentation as a very common sequelae, and always you will find only on the nasal cornea when compared to the temporal cornea. So these abnormally placed eyelashes are a thing. This is a nasal fold trichiasis. So where we normally remove a part of the nasal fold, in the fold will be there. That is an immediate worry. They will ask why if we remove the fold, then the actual pug appearance won't be there. It is not like that. A partial thickness in the longitudinal way you can remove, so that the fold thickness can be prevented. And it is always better to take the bites away from the eye towards the nasal part. So there is a way to do that, and then try to turn the sutures also downward while doing this nasal fold resection in pugs. The lag of ophthalmos is another important condition you will find in case of small puppies in toy breeds, where because of the presence of a macropalpebral fissure, these are all it's a circle. So they will have a macropalpebral fissure, and because of that, complete closure of the eyelid will not be there, and that results in drying, and they will go for because of this exophthalmos nature, you will find ulceration or sometimes pigmentation, etc. So the eyelid inability to close the eyelids is one major important thing, and if there is any root cause for that, for example, some space occupying lesions in the orbits or due to facial nerve paralysis, all these things should be ruled out, and then you can think about working on the narrowing of the palpebral fissure. So you can generally, we normally do it at the medial canthus, medial canthoplasty. Next, this is a deficiency that actually happens in the sympathetic innervation system to the eye. So you will find anisocoria. One eye will be myotic and another eye will be dilated in the Horner syndrome. Horner syndrome is not at all a worry, though it is brought to your ophthalmologist attention, because there is no vision problem in such cases. The vision of the animal will be normal. So it is only just a sympathetic temporary in deficiency. So and it comes out. There are different types of Horner syndrome, degrees, first, second, and third. So it is mainly happens due to some injury that happens on the brachial plexus subsequent to some trauma on the forelimb, or some infection in the ear. So that also can cause. So one eye is highly myotic when compared to the other eye. And you will also find ptosis and enophthalmia as in advanced cases of Horner syndrome. Anyway, it is not a worry because it is not going to affect the vision. Now the third eyelid is a very important structure which we were talking about because it helps in the lubrication. It acts as a wiper on the eyeball to spread the tear film uniformly so that it gives a good nutrition to the cornea. Whenever the free margin of the third eyelid is scrolled or everted like this, the property is affected, this function is affected, and because of this you will find corneal pathologies ensuing. So this is the scrolled third eyelid. The main reason for the scrolled third eyelid is a improper bend on the or improperly or poorly formed T cartilage. So there is on the T cartilage you will have a bend, and this bend can be corrected. So you first apply some stay sutures on the cornea like this, and then followed by the stay sutures you can put on either side. You can also put one more stay suture on other area. So try to reflect the third eyelid well. That is very important. All your basic principles of asepsis is important in this here also. And then after reflecting the third eyelid like this, you have on the third eyelid you have the conjunctiva, the palpebral as well as the bulbar conjunctiva. So now you are going to make an incision by holding the third eyelid onto the bulbar conjunctiva and try to take care of the cornea at the same time. The beginners can always cover the cornea with the moistened piece of cotton, flagellants of cotton. Now the conjunctiva, the palpebral conjunctiva, or the can be cut on the third eyelid, and you are slowly trying to reflect the cartilage. The cartilage you will be able to delineate well because of its coloration. It will be more white in color when you go down further. Hence, you will be able to identify it better, because though bleeding is there, initially you will have some difficulty, but with the help of a blunt dissection, after putting an incision, try to make some blunt dissection with the help of the artery forceps and go further down. Try to reflect the incision or retract the incisions on either side, because the bend is there. You have to remove the bend part, not the straight part. Now you can go further down. Yes, now you can see the cartilage very clearly, and now you have to separate the cartilage from the ventral aspect now. So you can push the hemostat down through the cartilage, and the cartilage can be lifted up like that, and then again you can do some blunt dissections to reflect it or to free the cartilage completely, and the bent portion of the cartilage alone can be stripped out with the help of the scissors. So you can use a conjunctival scissors, or the other scissors. The common scissors for extraocular surgeries we usually use are the Madras scissors. So that also you can use. So dissect further down. You will have difficulty because it slips and you won't be able to hold it. So that with the help of you can see my finger, it is trying to rest on the area, and additional assistance is not necessary because you will not have more space. Now it is reflected up, because this is a actual surgery, it is not a edited video. So that is why you are actually seeing the whole, how much time it is taking. Yes, now the strip is taken out, and you can either compress it with your artery forceps first and then cut to make an impression and on either side, and then remove the cartilage. So in this way It is something like I used to tell my students and also to the clients, like in case of chronic luxation of the patella in case of large animals, once you remove, immediately you will see some improvement. Okay, so the bend portion, once you remove, you will be able to see that the third eyelid will take its normal position. The free margin will be able to lie properly according to the contour of the cornea. So that is one important surgery which you will find. It is not very commonly seen in many as cherry eye, but you will definitely see in some breeds of dogs, especially Doberman. Superficial keratectomy. Now we have seen the eyelids, the glands. Now we are entering into the surface of the cornea. So you will get cases of dermoid like this. Dermoids are otherwise called, they are called choristoma. So this choristoma is a condition which occupies the misplaced hairy areas of skin which occupies on the temporal limbal area. It is very important. So it occupies a part of the sclera, it occupies the limbal area and also on the cornea. So that is the worry. And it causes what? It always causes some irritation to the cornea and frequent conjunctivitis, etc. So you can initially, if the patient is very young, you can plug the hairs and put an ointment and then wait for the actual maturation, and then you can work on the actual surgical procedure. And another thing is, because it is away from the visual axis, it is not going to cause any vision deficit. So at the most, sometimes there will be some scarring. So the last picture here, it actually shows you will find some granulations on the cornea. There also the superficial part of the cornea can be removed. So that is called a superficial keratitis in the pannus. That is pannus or a degenerative pannus, very common in case of German Shepherd dogs. This is a superficial keratectomy done before and then after. So you can see the iris very clearly through the dissected part. You will also find on the surface of the cornea, apart from this dermoid, as a non-inflammatory keratopathies. So the patient will be very fine. There will not be any discharge. There will not be any blepharospasm, no pain. So that is why there is no blepharospasm. And sometimes there will be some lacrimation because it is not smooth. So you will find some lacrimation. So some pigmentations or keratotic deposits you will find. It can be either calcium or cholesterol deposits or lipid keratopathies. So these are all called non-inflammatory keratopathies. So where also you can do a superficial keratectomy, and then followed by that we also keep an amniotic membrane, and then this is the case after the following the amniotic membrane with one sitting. So we can continue this again and then try to, because it is occupying the central part of the cornea, or we call it as axial cornea. It might affect the vision, and the owners are also worried. So that is why you can see the fundus through in the first picture behind. It's a normal chamber with a normal PLR. So a normal PLR indicates that the anterior chamber is fine. That is another indication. And always try to view these corneal pathologies against the tapetal background. Some tumors which arises on the eyelid, where cryosurgery is indicated. Cryogen is a very important thing which we normally use in ophthalmology. One is for tumors and another is for lens removal. So you can use cryosurgery, and this is equipment which is not a very costly one, which is cheap. So follicular growth like this on the conjunctiva can be removed. So this species is a rabbit. It is not either a dog or cat. This is very common in case of lab animals. So some 2 or 3 sittings of cryosurgery is very essential to reduce the. So this is called debulking. Cryosurgery we use mainly to debulk the tissue, and then from 2 or 3 sittings you will be able to completely remove the mass. So now cornea is important. We talked about the importance of the cornea in the physiology class with the refraction index. So this is the object that is placed in front of the eye, and you are getting an inverted image on the eye like this. So fovea is there. So that means it is a human lens, a human diagram. So in the air, actually the refractive index is 1, and in the aqueous humor it is 1.33. So because of the difference in the refractive index between the air and the structures inside, there is bending of the light rays happens, and you will get the image onto the cornea. Imagine if there is a problem on the eye, on the cornea, or in the anterior chamber, or on the precorneal tear film, all this refraction, physics of refraction will be affected. So that is why blurring of the image happens mainly. And you see the lens refraction index, again it is only 1.4. okay, that is why and it is 1.3 in case of aqueous humor, and it is 1.34 in vitreous humor. So that is why removal of the lens alone will not affect the refraction to a greater extent than the affections on the cornea. So opacities on the cornea is very important. We normally grade the corneal ulcers, corneal opacities. Opacities on the cornea is not a diagnosis. It is an indication that there is some disease that is happening in the eye. Okay, it is not a end stage. It is not a diagnosis. So grade 2 opacity means what? You will be able to see through the cornea. You are still able to see the fundic reflection. You are able to see a little part of the vitreous also, of the iris also. In the grade 3, you are able to see the more opacity of the cornea. In the grade 4, complete opacity, you are not able to see any of the intraocular structures. In grade 3, sometimes with a marginal illumination from one side, you will be able to see some part of the iris, the pupil also. So what is grade 1? Grade 1 is nothing of this. You will just find only a mild haziness, very mild haziness on the cornea. That is called grade 1 opacity. So when whenever the opacity happens, there can be sometimes ulceration also. So that is why you find ulcers on the cornea. Opacities on the cornea is an indication that it is the dog is having some problem in the systemic side. If it is a bilateral, or if it is an unilateral, it says that it is going for a glaucoma, or it is an end stage of enophthalmitis. In case of corneal ulcers, next is the corneal ulcer. So here, this is the maximum grade you can see in a corneal ulcer, where it is actually, there is no structure of an eyeball at all. You can see a desiccated eyeball rather in this. So these are mainly vision threatening problems, and but fortunately, if these ulcers are presented early, you will be able to treat it very well. And axial corneas actually pose a more threat when compared to the peripheral cornea, because the thickness of the axial cornea, we have said in the pachymetry that it is thinner. The cornea is thinner in the central part when compared to the peripheral part. So in such a case of corneal ulcer, you have definitely infections gaining into the eye, which results in endophthalmitis, and also it can also result in secondary glaucoma, or it will also settle as a phthisis bulbus. Phthisis bulbus is nothing but a shrunken eye, where you won't find any anterior chamber because it is a compromised eye where the production of the aqueous humor is also affected. Now the corneal ulcers, you have seen a very grade, even more than a grade 4, but now this is how the corneal ulcer starts. It is with a grade 1. You will find a slight opacities with the visible iris structures inside. So there is only a mild, very mild opacity. If it is a grade 2, you will find moderate opacities with the ulcer, unclear iris structures. In case of a grade 3, you will find severe opacity with an indistinct pupil margin. And in grade 4, extreme opacity obscuring the pupil margin. So you can use a slit lamp biomicroscope to identify in case of a very grade 1 and grade 2 ulcers, which occupies the very superficial part, and it occupies not the whole corneal surface also. So there are two beams here. So the distance between the two beams actually indicates the anterior chamber depth. This is a grade 2 corneal ulcer, which I was talking to you about. The iris structures are visible because you are doing a transillumination, not from the front. From the side, when you see, the chamber is there, but only thing is it is a diffuse ulcer. More surface of the cornea is affected, and here is the vision is affected. In a grade 3 corneal ulcer, it can be again a focal like this, but it is deep. So when it is deep, and though it is focal, it is considered as a grade 3 corneal ulcer with a indistinct pupillary margin because of the corneal edema. In a grade 4 ulcer, which is again an interstitial ulcer, where the animal will have a blepharospasm. So what you can do is, you can, after doing the test and all, you can instill proparacaine. This is blepharospasm is avoided in the second picture after proparacaine. So you will be able to do a thorough study of the peripheral cornea also, and then you can work on the next step. So this is the 7th post treatment after the surgery, after the tarsorrhaphy, and this is the 14th day after tarsorrhaphy. Sometimes just a simple tarsorrhaphy or a third eyelid flap, you will be able to cure the condition if the ulcer is not going to go further deep. But only thing is, it will result in a mild pigmentation as well as opacity in the center. If you want to remove further, so it is now we can call it as a scar. There is no inflammation. Inflammation is subsided. It is a very quiet eye with a scar. If you want to remove the scar, then you have to go for a DALK procedure. You have to remove the. You have to definitely go for a keratectomy. Remove that and then transplant the cornea from another patient. Mucous strands also sometimes uptake the fluorescein stain, so that you should be very careful when you deal with the fluorescein. So fluorescein study is very important in the corneal ulcer. Why? Because if the epithelialization is complete, at one point of time during the healing process, actually what happens, you can do the Shermer tear test, fluorescein dye test. So all these things will reveal that it is a grade 4 ulcer. Then integrity of the cranial nerves, the trigeminal nerve as well as the 7th cranial nerve. So neuro-ophthalmology also you can do. So all these tests you do, and if you are happy that all the intactness is there, then you can proceed for a actual surgery. So in doing so, you can think about either a conjunctival flap or you can also take a third eyelid flap. So during the healing process, if you are going to medically treat a patient without a flap, always I have seen in my experience that the transparency is good if you are not going for any surgical intervention. But what actually decides whether a surgical intervention is necessary or not always depends upon the cooperation from the patient. That is what I will say. If the patient is going to be very quiet, a good medical therapy with a good e-collar, you will be able to treat the condition. But if there are some threatening iris desmetocele, where the desmetocele also is going to break and the iris tissue will come out, then it is a worry. Then you have to definitely go for a flap.